So I'm Chuck Vega. I'm a family medicine physician in Santa Ana, California. I'm a clinical professor of family medicine at UCI. What does that mean? It means that I'm a professor, but what I really do is I see patients. So I see patients in the largest safety net clinic in Orange County. Does anybody know about Orange County from Orange County? Cool, good, very good. A couple, good, very good. So Orange County is great. It's the 6th largest county in the country by population, but it's by far the largest county that doesn't have a public health system, meaning here, you have a county hospital and you have county clinics. Orange County, more conservative, doesn't have any of that. So it really is dependent upon this group of safety net clinics to do outpatient care. And we do by far the bulk of the outpatient care for the county in terms of safety net needs. It's about total of 50,000 patient visits per year. So we're a pretty big facility right in the heart of Santa Ana. I love it. It's a great place to practice, and it's a great place to not only think about where family medicine and primary care is now, but where we are going in the future, because primary care is changing a lot. I assume you're here because you're interested in primary care. What appeals to you about primary care? As long as the group stays small, I'd like to make this interactive. Tell me why are you here? Justify it. Nobody? Yes.
It's interdisciplinary?
It is, and I'm going to highlight that. You're right. It's interdisciplinary, and it's becoming even more interdisciplinary. We have to work with other health professionals in order to achieve the best outcomes for our patients. That's the best approach, the team approach. Any other ideas?
Because the people who have, they get, the people who don't have, they don't get. So more on like the rural areas.
Yes. So it has a great impact on health disparities. So if you take a look at, and I've got a nice slide that very visually depicts, if you take away family medicine, what that means in terms of health provider shortage areas around the country. Any other ideas before I go on? Okay. So right. So we'll use the mics. We'll get to the mics. But this is just kind of an intro to start. I'm repeating everything. It's all good. So I'm taking this slide because primary care is changing a lot. And that's because consumers are changing a lot. I think when I used to think about this slide and what patients expect from their physicians, I used to make the analogy of going to a bank. Like, you want to be able to access your accounts anytime. You want to be able to, cash checks and do all those things. Now it's really more, I think, more modern analogies, more like Netflix. You really want it to be that responsive. You want your entertainment on demand now, on different media, whenever and wherever you want it. People feel that same way about health, and this is, I think, is particularly true of your generation. So you can see that, in terms of big surveys and big focus groups that our Academy of Family Physicians put together, the majority of patients want to be able to ask questions, and I want to be able to answer those questions. As a family doctor, I really love that I was helping the person who rented me a car today with her gas problem. I enjoy talking about health, and does she have boundary issues? Yes, you should never talk about your gas problem with a stranger you meet, even if they say they are a doctor. But it was certainly interesting to hear her perspective, and I went into family medicine because I want to help people, and I want to be able to do it anytime, anywhere. It makes a lot of sense. So the U.S., though, has some real challenges with its healthcare system. First of all, while we have, I think, in some ways, the strongest set of care, if you're in the right circumstance and you have the right type of illness, oh boy, we can do more for you in this country than anywhere in the world. And there's no better place, to have that rare tumor or that rare illness, because it can go whole hog in terms of the full technology and the kinds of expertise that we can bring to bear. It's amazing. But are any of you from Slovenia by chance? Or have close ties to Slovenia? Because I always need to check this before I state the following fact. Slovenia has a higher rated, they're 36th overall in terms of WHO rankings. So they're actually one ahead of the United States. Slovenia, people, we can do better. We can do better than being behind Slovenia in terms of overall care. And that has a lot to do with poverty, inequality of access to care, and it has a lot to do with efficiency of care too. We're not very efficient in providing care. Patients with a chronic disease in particular often don't receive the care they need, and then patients who, we often will repeat tests. It's ridiculous that, I had a patient this week who had a headache, got a CT scan, went to another provider, got another CT scan, and then came to me, and this is just a tension headache. But we already, not only is the patient exposed to a lot of radiation unnecessarily, but, he spent about $1,500 there for stuff that just didn't need to be done in the first place. So better coordination of care in particular, and better attention to what actually works for patients, and not just paying attention to disease outcomes. How much can we improve that ejection fraction of the heart? Can we lower the blood sugar to X? But more patient-oriented outcomes. Can we prevent blindness? Can you walk an extra 3 blocks? Stuff that really matters to people, that's going to make our healthcare system a lot more efficient. So you probably know that we have I think in terms of public health, one of the biggest risks we have in our country is just the overall cost of care. It's way too high. It's completely unsustainable. And so if we keep going along, now we're at 18%, then 19%, then 24% of our GDP is spent on healthcare, that means that healthcare is really going to start to suffer, and it's going to become much more divided between haves and have-nots. So that's something we need to address starting now. And Affordable Care Act, remember, it says affordable right in the title of that legislation, was really designed to start that process. I don't think it's by any means complete, but it's designed to start that process. And then, of course, we want to make it patient-friendly and create a more patient-centered type of system, which I'm going to describe in a minute. Access, I do a lot of work on access to healthcare. I think primary care is the way a lot of patients gain their initial access into the healthcare system, which is outstanding, and I always wanted to be that first responder, and no matter what the need was, for the 3-year-old with fever, to the 30-year-old with hypertension, to the 50-year-old who just has a funny thing on his eyebrow and just wants it checked out. I love doing that kind of stuff, and it's that mix of patients is fascinating to me. The interactions I have with patients, that especially over time, because all my patients are longitudinal, is very, very important to me. And so I want to provide access, and not just in a one-time health fair kind of basis, ongoing, to really support the patients so they can really improve their lives and get the most out of their own health. And we're not going to be able to do that, funny enough. I'm not a huge techie. I couldn't obviously get a flash drive to work before coming here because it was just encrypted. But I know that automation, the only way we can efficiently provide high-quality care and at a lower cost is by automating. We need to use more technology in healthcare. We're lagging behind every other major industry in terms of that field. So overall, you can see that if we want to be efficient and effective, we need to provide those basic healthcare services. We need to work on health disparities, coordinate care, and controlling cost. It's a big, big agenda. I think everybody's of the right mind. I think a lot of people have different ideas about how to achieve the right reform in healthcare, how to provide the best care to a population at large. And I think that a lot of them have good ideas. I don't discount anybody's. Everybody's got their heart in the right place. But one thing is, no doubt, it is a huge job. This isn't. If it was easy, somebody would have solved it by now. Is what I'd say. So no matter what your own thinking is on healthcare reform, be part of that effort. Have a voice, because a lot of times you may have an idea that it does contribute value. It's a complex problem, and we need a lot of different opinions to solve it. So that's where the idea actually came about for the primary care, or patient-centered medical home, rather, is through a congruence of different ideas about being more driven to serve the patients where they live and to promote the best healthcare outcomes possible. And so it took a bunch of different organizations to bring it together. And here's what it really means in terms of, this is the future of primary care. This is what we're evolving into now. And we could talk about 20 years from now, too, where we're going to be. But you have the personal physician. It used to be like you were the Svengali on the mountain, so that everybody would kind of approach you, and it was everything from the eyebrow issue to the severe hypertension to my daughter had a flutter in her heart 2 days ago, and what does it mean? Everything came to you, everything. All the form, and of course that means all the forms, all the refills, everything comes to you. And we need to disperse that. It's highly inefficient to have the doctor in charge of everything. And guess what? We're human. We make mistakes. We know we make mistakes. So therefore, it's actually dangerous sometimes to have that model where the physician is in charge of absolutely everything. A team allays that problem. So we're able to share the wealth. Everybody on the team, from a nurse practitioner to a PA, to a pharmacist, to a care coordinator, to a lifestyle coach, to a psychologist, this huge team of providers, each can have their own little specialty area and their niche, which provides but if you put it together and put the patient at the center of that little circle, you've got whole person care. You've got strong whole person care at the end of it, which is exactly what that next point is. And it's got to be coordinated. We have a great Health Connectors program, which uses undergrads at our clinic. I mean, just somebody who can coordinate all these complex systems and different insurances, different payment structures. It's very, very confusing for individual patients. And the lower income you are, the more you have language or cultural barriers, it becomes that much worse. So having simple interventions available to help coordinate care is tremendous, and it leads to better outcomes for things like heart failure or diabetes. Emphasize quality and safety. We're way too defensive as a field thinking about, okay, well, this was an error or this went wrong, but it wasn't my fault. And then you ask the next person, it wasn't my fault either. Everybody says, it's not my fault. Instead of thinking about it constructively, there's clearly a problem here. We've got some issue. We're not doing a good job of getting our diabetic screened for retinopathy. We're not doing a good job of getting these vaccinations on board. So how do we fix it? We need to have more of a fix-it mentality. Again, we in the medical profession lag behind everything else in terms of looking at ourselves and being critical and being constructive. And then we need to enhance access, and that's what I'm about. I do 2 half days per week in my regular brick and mortar clinic, 2 half days a week on a mobile clinic. I'm going to schools and delivering care right to low-income communities where kids are going to school. It's great. The parents don't have to, once they sign a waiver, parents don't have to get off work. Kids don't have to get out of school. I'm seeing the sprained ankles. I'm seeing the nosebleeds. I'm seeing seizures and asthma, too. I'm seeing some severe stuff. I'm seeing kids who just come over, and because they've had really disruptive lives, they have no vaccines, literally no vaccines. I've seen that. And so it's getting those kids up to speed and being there on a week-to-week basis. I love it. It's become a passion of mine. And I love that outreach and going to where people live and providing care. Nobody does that like primary care. Nobody. And we need to change the way we pay for medicine. So if we're going to have this whole person orientation, we need to pay for it. Not just that if I did 16 cataract procedures today, and there's people who can do that many, I'm going to get paid, $80,000. It's about, okay, do these patients see better? Do they live longer? Do they live happier? Are their chronic diseases controlled? Those are the things we should be paying for. It should be population-based and individually focused, meaning that we should be accounting all those individuals should be having better health. And that when we look at them in aggregate and we do data reporting on it, that's how we get paid. I think that would be a great system because without that payment, you can't incentivize all the other things on this rather lengthy list to happen. You need to be able to pay for it and make it sustainable. Okay, so here's our little house, and you can see at the foundation is family medicine because that's my specialty. We could talk about internal medicine and pediatrics, and that's where I draw the limit in terms of defining primary care for me. But I will say that I'm not a specialist basher or a tribalist. People think, well, you're in the program in medical education for the Latino community. You're a family doctor, so therefore you must be very pro-family medicine. Everybody should do it. I don't think everybody should do family medicine. In fact, I know very well medical students who should never, ever go into family medicine because they are born OBs. They are born pathologists. They are born surgeons. If you think about, doing this stuff and you apply it to your practice in pediatrics, in neurosurgery, whatever, if you're a good, caring doctor, gosh, we need so many of those. I know a lot of great family docs who believe in social justice, who believe in, this kind of model of patient-centeredness. But, we need a lot more specialists to buy into this too, if we really want to create the system that we have, that we dream of. So, yeah, even though this is about primary care, just remember, if you're a caring, happy, watching yourself, so self-monitoring is a big part of this. If you're a happy, caring physician, you are going to be able to get all those things and achieve those great outcomes at the top. I'm just going to address a few of the building blocks of PCMH here. So again, we have to admit our mistakes. So every day in the United States, in terms of quality, medical errors account for approximately 500 deaths. That's like a 747 going down every day in the United States, which would make a lot of news. But because this is happening so insidiously and so quietly, and frankly, there's attempts to cover this fact up, not a lot of people realize what a big deal it is. So therefore, we need to really embrace this idea of quality improvement across different practices and develop metrics so that we know what we're doing. So that's going to be part of your future. It's going to be patient care, but it's also going to be looking at more critically at your own practice, which the past generation of physicians, I tell you, this is completely foreign. This is not what they do. In terms of getting more access, so it's going to be, your future schedule will kind of look like this. You'll see 4 patients per half day, in your office. And that sounds great because my average is 12. For some practices, they might see 16. So those are those 15-minute visits, which is okay if you have somebody with a cold. I've seen like 3 colds in my entire 18 years of practice. It's like when I see somebody with a cold, I'm like, oh my gosh, I've heard about this. It's called a viral upper respiratory infection. Guaifenesin, and acetaminophen. That's all you get. It's like, but usually when I see a cold, and my ankle hurts, and my diabetes is out of control, and my mother's driving me crazy, and my kids driving me crazy, and so that's what I see. That's very much my patients. For the patient with the 16 problems, that's who you see in your clinic. For the diabetes patients who just need their numbers and needed to have a couple quick questions about, I'm urinating more frequently than normal, my vision's a little blurry, those you take care of in e-visits and you bill for those. So that's all electronic communication. Then you go upstairs and you do a group visit for your patients with depression. And you have your psychologist or your mental health specialist there too, and they're co-leading the class with you, and you check medications at the end, and you bill for all those patients too. So it's sustainable, but it's delivered in a different way. And by the end of the day, instead of touching, say if your normal schedule, you might touch 25, 30 different patients that day. Now you may have touched through virtually or in groups or in your brick and mortar clinic, you've touched maybe 100. I mean, that's the path to better care. And as those first slides exhibited, that's what patients want and expect, and that's where we need to move. Now we're talking about efficiency. And if you haven't figured it out, of course that's going to become very cost effective too, right? So practice organization, so this is where a team comes in. You don't have to answer all those refill requests. You don't have to fill out the 6-page form. Like I never begrudge, like I don't want to be the doctor who says, I hate these forms. Because forms sometimes, I actually filled out 4 social service aid forms because I have a lot of disabled patients. And that is a lifeline for my patients. If they didn't have somebody visiting their home twice a week to clean it, they would be one of those people you see on the news that lives in, some kind of terrible hoarding situation, and they some of them depend on those services to eat. Some of them depend on them to administer their medication. So I don't begrudge forms. Forms sometimes can be very helpful, but forms can also be a lot of bureaucracy. And I don't think that bureaucracy in healthcare, I'd love to cut it up to pieces, but I don't see it going away anytime soon. I don't need to fill out every single form, and right now I fill out pretty much every single form. So disbursement of those duties could be a great way to go. And then, but I also want, if the person, say I've got a front office person, they're a community college student, and they're getting trained in how to do the forms, because really that's all it takes. You don't have to have an MD or an RN degree to do it. I want to make sure that they know this is why it's so important for Mrs. Gutierrez. This is why, you really want to take care of Mrs. Latkova, is because if she doesn't have this service, if she doesn't have this drug, things are going to go bad. So one of the things as you build a team is find the right niches, but then make sure that it keeps patient focused, so people just don't feel like they're kind of going through a routine and running. It's not just a job. Healthcare is really a passion. Being a doctor is a passion, but I want everybody in that office to feel the same way about passion. We are going to be evaluated. Our patients evaluate these things on us. So they're actually looking, our metrics include, how satisfied are you with the experience from the front off, from parking to getting back on the bus or whatever and going home. We're all evaluated. And I think that's very fair. I want to be critical. And then how it's paid, I think I've talked about that idea of whole person care with population-based payments, where we take ownership for entire populations and make sure they're well. It also is a lot of, in terms of that technology, we need more decision support. The only thing, so you can give classes to doctors about, we should be screening for depression. Here's how to screen for depression. Here's how you score your depression sheets. And then you have somebody in reminding, hey, doctor, have you screened for depression? During their practice. And guess what? 6 months later, they're screening for depression at exactly the same rate. But if on their electronic health record, if you put a prompt that says, this person's depression score is blah, and it pops up, that gets a response. That gets a response over time. We make too many errors. We're pulled in too many directions. Sometimes it's just, checking the score of the baseball playoff or something like that too, or whatever, fantasy, fun kind of activity that it is. There's just a lot of distractions these days, is all I can say. But when you have technology behind you, it doesn't get distracted. It stays focused. And if you have the right decision support, that's the only thing that really makes a difference over time. And if you think about it that way and how efficient that is, and how cost-effective that is, that makes a big difference. So having point-of-care prompts to make me a better doctor is really important. That said, no machine, no program can do what I do. Like, it can't relate to people. We are so far from being replaced by software. It's not even close. Because patients do want that personal touch at the end of the day. They do want to know that there's somebody really invested in their care, and that could be, again, an RN, a pharmacist, a doctor, whatever, but also the way we interpret that patient's feelings, their emotions, no software in the world can do that, and I think that's a really special privilege too. So overall, when we talk about great outcomes, it's patient-centered, but physicians are going to get pulled along in this too. If you're getting scared about, well, all this sounds like a lot of crazy change, and I don't know if I just want to see my patients in my clinic kind of like my uncle did, or I know my doctor back home does, and that's my role model. Don't worry. This is actually going to be a lot better, and I think it's a lot more sustainable for you and your careers. Remember how many of you are thinking of going into medicine as MDs, DOs? So anybody want to take a guess at the burnout rate among MDs and DOs? What's the physician burnout rate in the United States in 2013? 30%? 40. Yeah, so, sorry, I don't have prizes. I have some gum, and I have a water, and I have a half-eaten sandwich. So anybody, but next time if you get it right, I'll give you the half-eaten sandwich. So yeah, and that's crazy to me. I mean, I would never feel like 40% of my colleagues, the people I know from medical school, my friends, my colleagues at UCI, the people who graduated from residency, and they're out there in the world of practice right now, I would never imagine that, almost half are burnt out. But the statistics are pretty consistent. It's not just one poll, because the year before that, it was like 35%. Now it's 40%. So we need to do a better job of taking care of ourselves as physicians too. This mentality in the age of, I'm just going to push it, it's a passion of mine, so therefore I'm going to devote my entire life to it, is not tenable. There's some superstars who can make that work, but what I see again and again is those people who really embrace that but don't pay attention to their own physical health, mental health, family life, huge. They're the ones, so they burn out. They have trouble. And, at UCI, the way I think about it is, I'm not trying to create somebody who's really stellar for like 6 years and go flames across the sky like a meteor with, getting all these awards and major research and all these accolades, and then burns out, develops an alcohol problem, gets divorced. That's terrible. I want somebody who's going to be steady and working for 30 years, adaptable, ready for these kinds of changes. That's the kind of physician we're recruiting. That's exactly who we need, because healthcare is going to change one way or the other. And then the practices will become sustainable. The economics will work out, and the practices, as they become, I think, a better system, will actually become more affordable too, and we'll start bending that cost curve back for healthcare, which is out of control. So you could say it's patient-centered and physician-directed. Yeah. As much power as us physicians have in anything. So I'm just going to speak for a little bit of time about family medicine in particular. We do everything. So we do inpatient, we do outpatient. We do a ton of office-based care. We see kids, we see pregnant women. We do hospice care. We do a lot of international work. I know that's something that's very exciting for a lot of people. And we really do try to so if you have a holistic view of if you think about, when you think about health, and you don't have to be at any advanced level of development to this. I think my 2.5-year-olds could have some idea about how they think about health and their well-being. One is pink eye right now, so he's thinking a lot about what happened to my eye. Why so itchy? Poor kid. Anyway, so if you see, actually, you'll see my eye like reddening over because everything they get, we get. So you'll actually see me go through various stages of conjunctivitis in the next hour. But we really do think about it holistically about patients' health. So what's their family life like? How are they feeling psychologically speaking? Are they satisfied with their lives? How's their ego doing? And what other habits do they have? Are they sleeping enough? Are they eating? What are they eating? All those influences. 90% of your health is determined outside of a hospital and clinic. So we actually try to pay attention to that. That's our mentality. If that's the way you think about health, you're a good candidate for family medicine. And so to me, it's all about the art of the possible when you're dealing with patients. Patients can't necessarily make that big change and change their diet and change exercise and, get off heroin and, find a job. That doesn't happen in a week, right? So you use continuity over time to really encourage those healthy changes. And sometimes, if you're a homeless person, my one adage I've learned, I've got a lot of homeless patients, nothing gets better when you're homeless. The key, I don't care even about your, heart disease, your risk of stroke. We have to get you stable in an environment where you have a roof over your head, because nothing I can do medically is actually going to be effective until that's stabilized. Nothing gets better when you're homeless. So that's the way I think about it. Sometimes it's the social work referral is the best referral I can make, not the neurologist, cardiologist, etc. And we care for everybody, here and across the world. We do a lot of public health. When I go on panels and, we're talking about community health and reducing health disparities, and there's a panel of 10 doctors, 8 of them are always family doctors. It's true. And not only that, I'm also, we're physicians, right? We're scientists. We need data. We love data. And there's strong data that family medicine, in particular, really makes a strong impact. So we reduce overuse of care. We do reduce the cost of care, but we actually get better outcomes in terms of both mortality and morbidity, meaning the cost of disease, like I can't walk, I'm going blind, and also the big outcome, death. And we do it in a way that promotes greater equity in healthcare. So when I talk about equity in healthcare, I like this slide. It's a little old, but I found it. I'm not going to lose it because nothing's really changed. This is all the health provider shortage areas, or HPSAs, in the country. So the blue is partial. The red is full HPSAs. Now, it's pretty bad. There's a lot of counties across the country that don't have enough doctors, right? So if you took away all the internists in the country, you'd add those areas in red, right? If you took away all the pediatricians in the country, that should be terrible. Where would they go? Then you'd add that many. If you took away all the family doctors, the map looks like that. And the entire country is now a huge HPSA. So we go as family doctors to places where other doctors dare not practice. Why? Because we can do all those things. We can see the 2-year-old, the 20-year-old, the 200-year-old. That'd be awesome if it was a 200-year-old. As I've gotten older, my practice has gotten a lot older, and so yeah, I do mostly geriatrics. I wouldn't be surprised if I have somebody who's about to celebrate their 200th birthday. There's some pretty cool older people out there. So we do a lot of the care in areas where it's really necessary in the country, and I'm really proud of that. That's one of the strongest things that drew me into family medicine. That and just being able to adapt as my practice adapted. I did OB when I started. I did a ton of procedures. I did a lot of sigmoidoscopies, and I did a lot of minor surgeries, and now I've become almost like a geriatrician, frankly, because I've stayed with those same patients over 18 years, and they're getting older. And I love it, because I love that relationship with them, because primarily what I wanted to do was always be about the relationship with patients. If they're happy to come back and see me, I'm very, very happy to see them. I'm excited to see them. So, and I do it in such a way where I work in a federally qualified health center where I know we're making a difference on health disparities just by being there. So, in terms of office visits and just so internists, there's more, the biggest group of specialists in the country is internal medicine, but family medicine is right behind it. But if you take a look at the primary care specialties, family med, internal medicine, and pediatrics, we do more office visits just in those 3 versus the other 127 specialties and subspecialties combined. So we do a lot of the care in the country. And we do a great job in doing it. So for adding 1 extra doctor per 10,000 population, this is population-based research, adding a primary care physician resulted in fewer deaths, 5%. Family medicine in particular, even fewer deaths, but adding a specialist was associated with more deaths. Doesn't mean they're going out and killing patients, but the utility in terms of mortality outcomes with specialty care isn't there for a lot of areas. In terms of having a primary care physician as your usual source of care versus a specialist source of care, primary care is associated with a lower cost of mortality and a much lower cost too. We order less tests because we know our patients. Why, it sounds maybe bad. I'm not trying to withhold care from anybody. I went all out on this kid yesterday, and poor kid, he passed out, but it was a prolonged pass out. He lost consciousness after running, so it was exertional, and then he had some tonic-clonic activity, some seizure-like activity, and it's like, this sounds like you passed out, but I don't know that for sure. So he's going to a cardiologist, going to a neurologist. He's getting a head MRI. He's getting some laboratory work. So I'll go all out when we need to go out. But frankly, the nice thing is if that kid comes back in 2 months and the same thing happened, but I know all that workup was negative, I'm not going to repeat all that workup. I'm going to talk to him about what the influence is, because I do know for a fact, because I've seen him twice now, he's tried to get out of PE 6 different ways, and he hates PE. There's something he won't talk about it yet, but there's something going on with him and PE and that teacher, and I've actually brought it up to the school. So they're actually investigating it this week, and we're going to have a meeting about it next week to figure out what might be going on, because it seems a little fishy. Now, I know that, but that's because I know my patient, right? And I'm trying to help him. And so, worst case scenario, if there's some kind of abuse or something going on, God, it's so important to expose that, right? When I think of healthcare, I think that's what I want to do. I want to be there for my overall well-being for my patients. That'd be huge for that kid and for all his classmates too, obviously. So this is just a summary of that change is coming. There's some resources if you want to learn more about family medicine. The websites are there. I'll leave that up for a minute. And so generally family doctors, we're friendly. We're happy to talk to you about your futures. And I think that's we are really going to be on the vanguard of this change. No matter it's not going to be straightforward. I don't think that we have a linear model to go forward and really make healthcare better. But I do think that we are going to be at the very forefront of it, and we get a lot of attention. We're at the White House. We're with members of Congress talking about the laws that shape the future of medicine. And I think that that's completely appropriate, and I'm really proud to be part of that movement. All right. And with that, let's do some questions. We should have 12 minutes or so for questions, and that's exactly what I wanted to have. So go ahead and come up to the mic if you can for your questions. And my foot hurts. Yeah.
With the increased popularity in nurse practitioners and PA programs and their increased autonomy over time,
right.
Is that relationship with them more competitive or complementary to what a family care, primary care work?
That's a great question. So it gets down to a question about turf. And I've heard people who are much better speakers and much smoother than me saying, no, we absolutely care. We want to be integrated. We want to work as a team. We understand this model. And then they go out and as soon as they leave that question, they go back to, I'm going back to my tribe and fighting everything I can for my group. Organized medicine is very much like that. And I completely disagree with it. It's backward. It's clearly not the way to provide high-quality, patient-centered care. And so I'm a big believer. So what I've done is I try to incorporate RN training and nurse practitioner training into a lot of the training programs we have at UCI. So med students, residents, and NP students, RN students are working together. And there's some really cool models in terms of simulation, in terms of clinical care. So we have the nurse practitioner students are coming with me to do health education in our local low-income school. You need that we need to start giving that culture of being a team earlier. And so when you grow up in that culture, it's going to feel that much more natural, and you're going to be able to build on it over time, as opposed to the way I was trained, where everything was really separate. Nobody knew. We worked in our little silos. We worked really hard, but the patient was just kind of left to navigate that on her or his own. And that's just, that model just doesn't work anymore. We know that leads to worse outcomes, so we can't continue with it anymore. And I think that that increased autonomy for every allied health professional is going to be the future, no matter what. And I think that's a good thing for you, the patient. It's a great thing. Other questions? Yes.
Hello. So you mentioned in your presentation that a lot of primary care is dealing with a wide variety of patients. However, in my future, I'd like to really work with specific populations, for example, HIV/AIDS patients.
Oh, yeah.
And I was wondering how primary care can really be able to treat those patients and their holistic health while focusing on that population.
Yeah, so that's a great point. So one story, I'll just share an anecdote really quickly. So I think my most influential experience in medicine was I went to school at University of Wisconsin, go Badgers, and they shipped us out to a rural site for 2 months. So 2 months, I was with 8 family doctors, and they did everything. So they did OB, they did surgery, they did everything in the center. And one thing I really valued was that they changed over time. So when the one woman in the practice got tired of doing OB, she just did emergency care. And so your practice is adaptable over time, and you can mold it. And I don't think that's going to change. You can still mold your practice, and absolutely, we need good care, particularly for patients with HIV. A lot of times their infectious disease doctor is their primary care doctor, and that's not why they went into infectious disease necessarily, right? And some of them aren't so interested in it or so good at it. My other valuable experience, I worked with an HIV primary care doctor in Laguna Beach, which has a large HIV population, a very different population from the one I was used to working to in Santa Ana, but actually still underserved, mostly uninsured. So it was really interesting to see that dichotomy. And I saw the value, and the main value he had was that continuity and that relationship with patients over time. He was from that community, so you could actually talk to them about, hey, I saw you at the bar the other night, and you were drinking 16 beers. That's ridiculous considering the drug regimen you're on. I mean, that stuff, rural Wisconsin the one thing that rural Wisconsin had in common with Laguna Beach was 16 beers. There was definitely, you said, that connection to patients and to community was really important in both settings. And I love the malleability of primary care. I use it mostly based on what my patients and community need, but I certainly have interest. I want to pursue certain things.